Hello, everybody. Dr. Al Heuer here. I am Terry Shenfield's partner in A&T Lectures. I do other things, including I teach at Rutgers School of Health Professions, as well as the Respiratory Care program at County College of Morris. And I'd like to welcome you, and I'd like to basically say that over the next 50 minutes or so, I'm going to be presenting on another topic that's near and dear to my heart, and that is reshaping our workforce to prepare for the future. So let's take a look at some of the learning objectives. So over this presentation, we'll be defining and distinguishing amongst key terms, including burnout and post-traumatic stress disorder. We'll be describing the prevalence of burnout and post-traumatic stress in healthcare pre-pandemic. Yesterday, or in another presentation, we actually were talking a bit about respiratory care, but the same could be applied to nursing, how it can be a pretty stressful job. Forget about COVID. Aside from COVID, pre-COVID, be a stressful job. So, heavy workloads, at times life or death. There could be simultaneously several physicians, several nurses that need our attention at the same time. Well, maybe the patients they're caring for need our attention. So you're getting pulled in a lot of different directions. It's complex. I could go on and on type of deal. And then you had COVID come along and make it even more. So there was a stress factor for the duration, and that stress factor has increased since the pandemic. We'll describe review the extent of and the ways in which COVID pandemic may have impacted our workforce. This is not strictly a COVID presentation, just to be clear on that. But I can't really talk about the topics, of burnout and post-traumatic stress without, working that into the mix. Compare and contrast strategies to mitigate workforce burnout and post-traumatic stress disorder in general, and that related more specifically to the COVID response. I'll also be furnishing you guys with additional resources should you want to learn more about this. So some of the key terminology, and I originally had more terms in here, and I just really wanted to keep it a bit more focused. But one of the terms that we're going to be examining, you can see this guy here. That's Terry went before his hair turned white a few years ago. Occupational burnout. So results from chronic workplace stress that has not been successfully managed. Some of the key symptoms are characterized by feelings of basically exhaustion, energy depletion, increased mental distance from one's job. So this kind of lack of engagement. So in one of my other presentations, I talk about engagement, one of the keys of, getting engaged to advance our profession. One of the factors that works against getting engaged is when people are feeling burnt out. Certainly when people are feeling, post-traumatic stress, that would be even more so. But again, increased mental distance from one job or feeling of negativity or cynicism related to one's job. And we are seeing that, to probably a greater extent now. Reduced professional, basically efficacy. And you could argue efficacy and efficiency. Post-traumatic stress disorder is actually a mental disorder. So think of it more in terms of a diagnosis. Occupational burnout is not, there's not an ICD-10 code necessarily for occupational burnout. However, when unaddressed, burnout can lead to other things that, could lead to depression. That's a bona fide diagnosis, can lead to post-traumatic stress disorder and depression. And PTSD, a mental disorder, may develop after an exceptionally stressful or threatening event or events. It's not funny, but it's ironic that there's individuals that my brother was a paratrooper, and so he jumped out of all different types of planes or whatever, and he was saying that he encountered a drill instructor who didn't jump anymore, and he had I don't know 200 registered jumps. He had a lot of jumps. And on his 201st, he got to the doorway, he looked down, he just basically said, I can't do this. And he didn't do it anymore. So it's a hard thing to predict. He got to that door and jumped, whatever, 200 times. It was a lot of times. And that 201st time, it just wasn't going to happen. So it's hard to predict. Sometimes it can just be one, very stressful, traumatic event. Sometimes it's, jumping into a combat zone, multiple times. There's an expression, it's harder to get people to go into combat second time around because they know what they're going to be encountering. They know the stress that's actually involved. Again, it can occur after a single traumatic event or prolonged exposure to trauma. Some of the symptoms include persistent and intrusive recollections. Could be nightmares, things along those lines, or just when during the course of the day. Avoidance of stimuli related to trauma, negative, if you will, alterations of cognitive mood, hyperarousal, so that people are, when they're awake, they're really hyper awake, or when they're trying to sleep, they can't fall asleep. Secondary traumatic stress disorder is a bit of an interesting phenomenon. So it's a form of PTSD occurring in caretakers of those who have experienced or are experiencing traumatic events. Think about that. So it's like when I don't mean literally, but it's like a contagion that you're near somebody who's very stressed out and it's stressing you out because they're stressed out. Brief history of burnout in healthcare. So it's not a new phenomenon. In 1961, Graham Greene basically wrote a novel, a burnt out case, which dealt with a doctor working the Belgian Congo with lepers, so folks that had leprosy. And it's an interesting read. Okay, it's an interesting read because it was just it was just omnipotent. It was around them all the time, and and plus it was also the Belgian Congo. The environment itself was bug infested, humid, wet, hot. Just the conditions were, and then things like potable, drinkable water were a challenge. And then you're also facing all that, and then you're then treating lepers. And I mean that in a derogatory way, but so he really talks about the whole issue of burnout. 74. American psychologists used the term burnout. So now we're getting it, now it's starting to be, a characterized phrase. His scientific article, Staff Burnout, paper was based on observations, volunteer staff, including himself, at a free clinic that was treating drug addicts. And one of the added dimensions in this particular case is you're looking at some of these drug addicts were like, they would appear at the clinic over and over again. For things related to malnutrition, things related to certain types of infections that were inherent in folks that are immunosuppressed, things along those lines. And seeing the same people, and then every time you see them, they're getting a little worse, and they look worse. 1981, Maslach and Jackson published an instrument for assessing burnout, the Maslach Burnout Inventory. It's the first such instrument of its kind, most widely used burnout instrument. And it's been, by the way, adapted in not just in healthcare, but it's actually been used outside of healthcare. So, it was originally focused on human service professions, but it's been, if you will, more widely used. I know our colleague Gary Kaufman, we've had some interesting conversations actually. And I know that he did a project where they were in I think it was Pennsylvania, where they actually administered this to a lot of the respiratory therapists in that state. Got some very, very interesting results. I don't want to steal his thunder. He may be talking much more about that later on. So I apologize, Gary, if I stole any of your thunder there, but I'm intrigued. So, you had my undivided attention when you were talking about that. 1990s, WHO adopted a conceptualization of burnout. It's consistent with Maslach. Although the organization does not treat burnout as a mental disorder per se. Record number of Americans are quitting their jobs. It's not just in healthcare, just quitting their jobs. They're quitting, or they're quiet quitting, which is like, I'm still working, but I'm getting paid, but I'm now, disassociating myself from, mentally disassociating myself. So according to a report from the Bureau of Labor Statistics, record-breaking, over 4 million Americans across a variety of industries are quitting their jobs in a particular month. The highest number of quits since the agency began tracking in 2000. Food service, retail, healthcare industries are amongst the hardest hit, no surprising. In particular, over 500,000 US workers, healthcare, social assistance positions resigned or quit their jobs in from the last August. So, in months' time. According to Mark Zandi, chief economist at Moody's, if you guys watch like Squawk Box on CNBC, you'll see Mark Zandi come on sometimes. But you really talk about workers now have the opportunity to exert pressure on their employers. We're now seeing labor market that is tight. It looks like maybe it's loosening a little bit, but it's still quite tight, meaning it's an employees market. And prospects are becoming increasingly clear that it's not going to, it's not going to change anytime soon. It's now going to be a workers' market, and they're empowered. I think they're starting to flex their, collective muscles, is what he was actually saying. And there was great variability in healthcare, and particularly in respiratory care. There's great variability to what that means, from one organization to another, in one region or another. That there's certain organizations that really have looked very carefully, not just at financial rewards, but quasi or non-financial rewards, quality of life, work-life balance, and really done a lot to try to gain and to improve in those areas. There's many other organizations that talk about it, and just it's just maybe they've thrown a 3% or 4% increase at their employees, but it ain't enough. And if you just listen to the constituent workforce in those organizations, they're saying, it ain't enough. So a little bit on the mass lapse burnout inventory, because I just can't, drop a bomb on you guys and not talk about it a little bit, but, consists of 22 items, individual item ratings, so no burnout, to a 6, high rate of burnout. Total score, score of 0, no burnouts, a score of 132, high burnout. Scales, it's got these domains, if you will: emotional exhaustion, depersonalization, and personal accomplishment. It was designed for professionals in human services. It is appropriate for respondents working in a diverse array of industries: nurses, physicians, health aides, etc., police, but those correctional officers and others. Focusing on helping people live better lives by offering guidance, preventing harm, and, if you will, ameliorating, is modifying, if you will, cushioning physical, emotional, and cognitive problems. And again, busy slide, but just to give you kind of an idea on what sort of issues are included in this survey. So I'm not going to read all these to you, but for instance, the first couple ones: I feel emotionally drained from my work. I feel used up at the end of the workday. I feel fatigued, and they go along, along those lines. So again, the related response to prolonged and severe stress, burnout, depression, post-traumatic stress, they're not all the same thing, but they, it's not unusual for people who are burnt out to feel depressed too. Think about it. If you feel depleted, there's things that you want to go out on your days off and you want to enjoy life, but you're just too exhausted, both physically, emotionally, intellectually exhausted. You need a day to recover. And it's not unusual for folks that do, 4, 5, 6, 12, 13-hour shifts in a row, whether they be day shift or night shift, on their first day off. They're just not good for too much of anything at all. That's one thing, okay? But where it's, you work 3 days in a row and you're just you feel that way, and every time you do, and you're taking longer and longer to kind of shake it off and get out of it, that's significant. That's something to be noted. Healthcare workers are more predisposed to stress and its consequences. So really talking about, again, pre-COVID, just overall shift work. You work on holidays and weekends, unless you're a physical therapist, then you're not. I'm kidding. I'm just kidding. A little levity there. I'm just making sure you're still awake. Healthcare is one of the most complex industries for a whole lot of reasons. It indeed is heavily regulated. You have, the end users is one of the few industries where, you use a service, and many times, you're using that service and you don't know what the cost of that service is until later you get the bill, or how much is going to be covered. It's just a whole lot of things going on. High stress, life and death situations, not always, but let's face it, those exist as well. Heavy workloads, dynamic environment, manageable assignment can quickly change and become, I don't want to say unmanageable, but something that's very challenging. Disconnected leadership. I'm not saying they're all disconnected, but many times they are. One of our doctors, he's the head of a particular department. If I say what department, I'll tip my hand. But he basically jokes, he's a chair, he's a department chair. And he jokes that when he goes to corporate on a Friday in the summer, it's after like lunchtime, there's nobody there. There's nobody there. It's like a hello. There's like an echo chamber. Where did they go? I don't know. They went to the short houses. I don't know. But he's not an embittered guy, but he's just like, come on. And he's a chair, but he's also, I'll say he's a surgeon, but he's a chair as well, the department chair. So it's kind of interesting. Like we'll be there till 8 o'clock on Friday in the summer, if we can get out by 8 o'clock, whatever. So so we have these kind of baseline issues, and we have the ways of actually, valid ways of quantifying, measuring it. So how did COVID-19 exacerbate things? You guys have the answers to a lot of this. You didn't have to be in the trenches. My wife was, I want to say, she's outpatient nurse. She had her own issues that she was dealing with at the practice, cardiology practices, more than one office that she helps oversee. And they had their own challenges. But if you're not even in healthcare, the feeling of isolation, the fear of, am I going to get this disorder? And if I start feeling badly, is it psychosomatic? Am I getting the common cold, or do I have the COVID? Or something else, or some other, so it's just, at first it was uncertainty. How contagious is it? I mean, we were in the trenches. So, many of you were in the trenches. So that was something. It wasn't just this, well, I'm in my house and, I need to break down eventually and get some dish soap, milk, cook, milk, bread, you get the idea. But I'm afraid to do so. Why does it make, some people so profoundly ill and spare others altogether? Or spare them, they get it and they're not really that ill. Heavier workloads, and in some cases they were much heavier workloads. And then the equipment shortages, protective equipment shortages, maybe hoarding, maybe not, maybe rapidly changing protocols and procedures, including the ridiculous, we can wear bandanas because we're running out of hoarding masks for another day. More suffering, death, dying in the ICU. So it was really a big deal, just a big deal. Think about, the mechanically ventilated, real sick COVID patients and, mortality rates of, 40, 45, etc. percentage. It was a big deal. And the point of it is it left a mark on many of us. Okay, it left a mark on all of us. Some just the actual degrees varied. Again, disconnected leadership. I don't mean to say I'm just throwing stones at them, but it was just, I just remember there was a few occasions somebody must have told the directors and up, you need to go into your units. And it was almost like they came and they looked like mortified. They looked like, oh my God, I'm this close to COVID. And I said, we work here every day, and it was almost like I got the feeling that they burned their clothes before they went home that day. It was just like, and then you didn't see them again. There was a few leaders that actually came into the unit, stuff like that, but there wasn't, no. Anyhow, support for long haul patients, but not long haul clinicians. So this is another, very candid person, and there's certain topics that are really near and dear, to my heart. This is yet another one that I think that the long-term impact that COVID had on us, on a workforce that was already, if you will, tipping the scales or nearly tipping the scales, is still underappreciated, and the impact that it it's having now. But the research eventually, the qualitative and quantitative research, the survey research and interview research that will eventually mature, will look at this and say, no wonder why people just left, because it was beyond what the scale could actually measure in terms of stress. So, COVID exacerbating things, pre-COVID factors, the COVID related factors, and increased burnout, turnover, and morale. And it's not over. It's not like, oh, we've got our hands around this. So burnout is also not new. It's not a new phenomenon in healthcare. It's also not new in respiratory care. And I know we have at least one nurse/respiratory therapist in our audience. So same thing. A lot of this can apply to nursing as well. 1981, I was graduating from Montclair State University with a degree in public administration, headed to work for Prudential Insurance Company for the next 13 years after that. Yes, true. And entering business school, entering a master's in business administration program. So Respiratory Therapy Journal featured a piece entitled Coping with Burnout in Respiratory Therapy or Respiratory Care. Findings, factors such as inconsistent on-the-job training, heavy workloads, lack of acknowledgement by other health professions were contributing factors. And I just included the citation just for giggles, but just the sort of thing. And honestly, I kind of felt it when I found this piece. I was just like, so it's not a new phenomenon. Research related to burnout, respiratory therapists, so Omar. So this is now going from 81 to 2022. So I'm going to be citing some of the research so that you get the sense that I have, I personalized some of this presentation, but the main thrust of it is not about me, okay, but is about what's been published, where are the gaps, etc. So let's take a look at some of those things. So this Omar piece in 2022, the aim was to report the prevalence of burnout, the impact of leadership and work conditions amongst respiratory therapists in certain specific settings. The conclusion, this study suggests that a high burnout rate amongst RTs, the reported rate was significantly correlated to work conditions and leadership behaviors, because that was in the secondary analysis. Recommendations, organizational efforts should be directed to combating burnout through the identification and adequate management of key causative, precipitating factors. And the citation I have here as well for any of you that want to drill down more on it. Impact of COVID on respiratory therapy burnout, Evans, so around the same time, 2021. This was, obviously an earlier piece, editorial review of related literature. We talk about the findings, they identify personal fears, becoming infected, infecting loved ones. The first day, it was a Saturday, the first time I was in a, COVID ICU. I remember I was in medical ICU, and when I got home, and I did this ritual that I started doing every time before I went home. I'm like wiping this down, wiping that, wiping that, just throwing out my socks, putting on clean clogs, etc. Then I got home, I was the guy changing in the garage and running through our breezeway and with my underwear on. My wife was yelling at me, but in a playful way. Took a long shower in my life. I'm sure I'm not alone in that respect, but fear of becoming infected, but infecting my my lovely wife and my friends and family. Social isolation, emotional distress, workplace fear, insufficient access to supplies. This isn't the entire list. This is just you guys, what many of you or all of you have experienced: insufficient access to supplies, environment overall, and then the equipment, running out of ventilators, inadequate staffing paired with high patient volumes and really high workloads. And the citation is here as well. So it's kind of a big deal. Explored some of these factors, and almost like I felt like when I read this piece, it was like, wow, I felt this way, but I didn't think I was the only one, but I didn't realize it was this widespread. So a little bit more. So the findings on this piece, summarized findings of the COVID burnout survey. And then what it found was the majority of respondents strongly agreed that burnout is a major problem. That was 93+%. Respiratory therapists have similar risk of burnout compared to other healthcare professions, 92% roughly. 72% stated that they had personally experienced burnout at some point in their career. Not unlike studies of other healthcare professions, RTs report higher levels of burnout within their departments when taking the survey compared to pre-COVID-19. Despite the high level of burnout, few respiratory therapy departments offer resources to the staff. That's big. That's a big deal. So we kind of know there's a problem. You guys may sense it intuitively, okay? But I will tell you that not just this piece, okay? This and other similar pieces basically say this is a problem, okay? Now, this, let me be clear. The fact that the burnout and the stress factor that was baseline, and then the contribution that COVID in many ways made to it is huge. A lot of people feel that. A lot of RTs and nurses feel that. Despite it, however, Few departments offer resources, or they put a poster up, go see. Concern is our organizations. You can go and, it's basically counseling, support and counseling. They put a poster, they think they've done enough. It's just, and now they're feeling it. People are just like, they have nurses and RTs. They're not, they have more of a mercenary mindset. Yeah, I'm here for now, but I'll do this for now. You could throw a little more money at me. Okay, I'll stay for now. But you know what? You guys showed your true colors. It's just like, and you're kind of slow to even respond now. That people don't just need money thrown out. They need to feel supported. Okay, they need to feel like, number one, that their burnout and the stress level is being recognized. And there are resources being made available for them to deal with it. And it's happening in some places, partially happening in others, and not happening to a large extent in many, many others. Most frequently identified key drivers for burnout in this particular piece: poor leadership, almost 32%, high workload, 31% roughly, insufficient staffing. Again, those are all in that, high 20s, low 30s range. This was an interesting one as well. Women on the COVID front line, not simply, again, I don't mean to oversimplify, but, just kind of summarizing, it was women felt it more than men. And there's more studies that are either being published or on the horizon for being published. Okay. So COVID-19 pandemic represented novel battleground. Okay. Women taking the center stage. Okay. As physicians, respiratory, and this piece actually mentions respiratory therapists, nurses, and the like. Pandemic disproportionately impacted women, because then they also had the issue of, and I don't mean to sound sexist, this is what the study showed, that the women many times were the ones that were dealing with the whole school issue and homeschooling. And then, and then as they started to open up the schools, then it's open today, it's closed tomorrow, and this and that and the other thing, and they're social distancing, and then maybe their kid gets sick, or the kid gets sick, maybe doesn't have COVID, but can't, and all those things. Women felt that, meaning it impacted them to a much greater extent than it did men. So the findings, while pandemic has facilitated several positive advancements in addressing these challenges, still much, much more work to be done. Women to achieve equity and optimal support. And again, the citation is included here for any of you guys that want to drill down more. If you can't tell it by now, but in preparing this presentation, it was an eye opener for me too. I knew some of this material. I do a lot of reading, but to then put it in a presentation, it's like, I kind of felt like, wow, I felt validated. I felt like, I know I talked to my colleagues, and I know I read some stuff on this, but I don't know actually, I haven't really done a systematic review of the literature to see what's actually published on this. So it was cathartic, and actually I'm still processing it, if you can't tell. But let's look at this piece. So you have this Labrage and De Los Santos piece, also 2021, fear of COVID-19, psychological distress, work satisfaction, turnover, lions and tigers and bears. The overview, or the aim, project sought to examine the relative influence fear of COVID-19 on nurses. This is with nurses, work satisfaction, other things. The findings, overall composite scores, they looked at these various scales. So it wasn't just one. Fear of COVID-19 scale was 19.2, so it was high, very, very high. Job role, attendance of COVID-19 related training, predicted fear of COVID-19. Increased level of fear of COVID-19 associated with decreased job satisfaction, et cetera. The significance, addressing the fear of COVID-19 may result in improved job outcomes for frontline nurses. And again, some of this could be potentially generalized to respiratory therapists. Talking about frontline nurses, frontline respiratory therapists. This one's looking at frontline nurses, but it wouldn't be unreasonable to say that a lot of this applies to RTs as well in the front line. Organizational measures are vital. Organizational measures are vital to support the mental health of nurses and address their fear. Peer and social support, psychological, mental support, providing training for COVID-19. A lot of places it was just, when I say survival, it was just getting by. So a lot of this really didn't happen. This is reflection on, if it happens again type of deal, or as the mini spikes happen or mini surges happen subsequently. Costs. of burnout and post-traumatic stress disorder, individual costs, looking at, the physical and psychological debility, the unwillingness of most clinicians to look after their own welfare, to look after that of their patients, higher levels of substance abuse, undermining of family dynamics, lower levels of self-esteem. Also, individuals, we know that, individuals, things like dental appointments, things like wellness care and things along those lines, those things suffered as well. So it wasn't just, some of the issues that I've mentioned here, but there's other things as well. From an organizational perspective, again, the great resignation, whether it's a literal resignation or a, if you will, distancing one's level of commitment. Higher level of commitment before, now it's, you know what, I've seen enough. I just need to kind of pull back. I'm not quitting, but I'm pulling back my level of commitment. Higher turnover, lower morale and performance, higher level of absenteeism, higher cost of recruiting and training new employees, high cost of agency employees, travelers/agency. I don't know about the unionization thing. That's something I think could happen down the road. We'll see what happens, but there's been a little blip, where if you will, where the workforce is not highly unionized, the needle hasn't ticked that much upward. Okay, but it should be interesting to see if there's any movement in that down the road. Societal, like unemployment rate versus workforce participation. So we say unemployment rate is still low, but workforce participation is a different figure. The unemployment rate does not include individuals who've stopped looking. Okay, workforce participation is something that looks at that. So individuals that are just out of the game altogether, they're not included in the unemployment rate. So devil's in the details. Lower quality of healthcare, potentially. Think about it. If your staff is burnt out that are providing the care, it's not unreasonable to say that the quality of care is not going to be as good. Higher cost of actually healthcare. Who's paying for these agency people that are making obscene sums of money, or a sign-on bonus or a retention bonus, or it's coming from somewhere. Getting through COVID-19, so keeping clinicians in the workforce, barrier piece in 2021, risk for contracting, COVID-19, challenges, medically complex patients. All of these factors again contributed. Employers and organized medicine to take tangible steps to revert to, if you will, preserve the clinical workforce. This study, I've summarized it on more than one slide because they made a bunch of recommendations. Okay, and I'll just kind of briefly go through some of the major ones. Ensuring physical safety. So think about Maslow's hierarchy of needs. Physical safety by reducing clinicians' risk for contracting. Safety, one of the lower needs. It's not self-actualization. It's basically, food, shelter. I need to feel safe. Like I need to feel warm and safe, or relatively speaking. Okay. Provide practical support in areas that clinicians identify as causing emotional stress that we weren't even measuring. And again, like I want to emphasize the survey, and it was a COVID survey. It was done in our organization. 5 hospital. The hospital I work for is the #1 ranked hospital in the state of New Jersey. Now I'm saying #1 ranked in their COVID survey, the workforce survey. They couldn't even identify respiratory therapists as, when you check the box, doctor, nurse, physician assistant, nurse practitioner, other. We were other. Okay, that just speaks volumes. Just again, if I sound angry, maybe I'm a little bit angry. I'm actually as surprised as anything. That I expect more from a hospital that's the #1 hospital in the state of New Jersey. You guys should expect more from your employers. Maybe you get it. I don't know. They did certain things right. They didn't do certain things right. That was one of the things they didn't do right. Extend support for clinicians who are parents. So really that, again, I said before that women, but it could be a man who's got, he's got the primary custodial rights of the kids, whatever, and he lost his spouse and he's mom and dad, but it does disproportionately fall on women, but basically recognizing and providing support mechanism for parents and primary caregivers. Reduce administrative tasks that are not mission critical. So, we did a lot of things. This is where we actually did some real good stuff, where we frankly did fewer vent patient checks, but some of the administrative burden was alleviated. And, if they tended to be less critical, if if your charting was a little bit off, I'm not talking about something that was egregious, but something a little bit off, they showed you some latitude. Confidential support, clinicians' mental health in a confidential manner. Actively encourage clinicians to use their available time. That didn't happen as well as it perhaps, could or should have in a lot of places. Coping with death and dying, so tools to help respiratory therapists handle frequent exposure to end of life. This is a piece, notice 2019. Okay, so this is not, this presentation is not a COVID presentation. It may have, parts of it may appear like it, but it's not. This is something that was published in 2019, meaning it was really conducted, and the review was done before that year, so before COVID. Removal of mechanical ventilation is a duty of respiratory therapists. Exposure to death on a frequent basis can take an emotional toll. The findings were a vital component respiratory therapy is managing mechanical ventilation, dealing with death and dying. Therefore, the education and recognition of death anxiety are important for the respiratory therapists. We're not even talking about the respiratory therapist who, because of religious or ethical reasons, won't do this. We're not talking about it. We're talking about the ones that do. Okay, because someone is willing to do something doesn't mean it doesn't have an emotional toll. So recognition that everyone handles this, having to remove somebody from mechanical ventilation differently, okay? And again, react to these changes differently. Formal grief counseling programs should be embraced. Managing perceptions and stigmatizing of help seekers and other things along those lines. Mitigating burnout, recognition, treatment, resilience. So some of the things that can actually be embraced by employers. Support your employees. Mentioned in this lecture and other lectures that there's no substitute. People need to feel supported, not just your siblings, your kids, your spouse, your best friends, stuff like that. People need to feel supported even in a professional environment. And the actions, not just the words, people need to feel supported, not just hear the words. Formulate properly resource and promote programs to help treat burnout, maybe even avert it. If it occurs, to have it occur less frequently and less severely. Meaningful, sustained, wellness supported programs aimed at self-identification, third-party recognition, evidence-guided or evidence-based treatment programs. Provide health insurance coverage for those programs where appropriate. So don't have people, oh, I have the program, but it's going to cost me, $50 every time I use it, not a $5 or $10 or $15 copay. It's going to cost me something, so you might as well not have it. Where appropriate, debrief behavioral issues in more of a supportive and less of a punitive way. Again, it's easier said than done, but again, some organizations can thread that needle more readily than others. Destigmatize burnout and post-traumatic stress disorder. For employees, educate yourself on available internal and external resources. Talk to people. If you have people you really trust on the job, or you have people you really trust around you, I'm feeling this way. You have any, thoughts, or somebody who sought help, like how did you go about this? Humility. If you feel like you need help, seek it. Okay. One of the lessons I've learned is, you can't be everything to everybody, and we're all vulnerable at times. And, it's something I don't do readily. I'm a very proud person, but better to ask for the help than to say, I'm fine, and you're not fine. Stay tuned to the behavior of those around you. Do they seem like they need help? Avail yourself of support and treatment services. Those are just some of the things, it's very difficult because, sometimes when you're feeling stressed out, you're feeling depressed, sometimes you don't have energy to do some of these things. Okay. You're just kind of like, you're in your shell. So it can be easier said than done, but the point of it is, if you recognize somebody around you that looks like they've become withdrawn, maybe try to reach out to them a little bit and be a helping hand to them, just to kind of break that shell or that cycle. Mitigating post-traumatic stress, social support, very, very important. I remember talking to one of my colleagues during COVID, and I said, sometimes I'm driving in my car and I start crying. And, I'm like, and then I get through it. And sometimes I don't even know why. Like, I feel better after I cry, and he said, I cry sometimes too. I thought I was the only one doing that, and the more I talk to people, it's not funny, but the more I talk to people, they were like, nurses and respiratory therapists are like, yeah, I cry sometimes too, whatever. It's just whatever. So it's like, it's, social support. So sometimes just getting that validation, it's okay. It's okay to cry. And if someone's obviously doing it a lot, then they probably need more than just to be talked to by a friend or a loved one. They probably need some professional support. Group trauma, so focused on cognitive behavioral therapy. So guided group sharing can also be effective. You can see a lot of the support programs are aimed at that, not just Narcotics Anonymous, Alcoholics Anonymous, but some other, there's group therapy for people that are depressed and have various psychosocial disorders. Guided self-help interventions for depressed and anxiety disorders are being used as alternatives to face-to-face therapy, etc. Something, just the theme of this slide is there's more than one way to approach these things, and it may not be just one thing you do. It may be a combination. It may be a guided self-help or social support and medications. So medications, basically, it was so found to there's this Prazoin was found to reduce nightmare symptoms in veterans with post-traumatic stress disorder. So there's medications out there that aren't just serotonin reuptake inhibitors, whatever, but they work differently as well. Immediate and intense treatment, if even inpatient if it's needed. People that it's hard to predict. It's also hard to predict. You get people that are exposed to the same stress for a long period of time, and then it's just that additional day that sets them over the edge. AARC best practices, productivity and staffing. So really looking at in terms of the staff level and the if you will, excessive in some cases workload. This is what the AARC has to say. And obviously, when you're pushed to your limits as far as workload goes, or maybe beyond your limits, it can affect you. It can be stressful. It contribute to burnout. It could potentially contribute over time, particularly when combined with actual traumatic events, can contribute to a post-traumatic stress disorder. So any system, this is what they're saying, used to define respiratory staffing should recognize and count for all activities required of respiratory, not just what's reimbursed, okay, and should account for the uniqueness in each facility. They say that unweighted metrics such as patient days should not be used to determine respiratory therapy staffing, okay. One of the things that Gary was making some good points yesterday in another one of our presentations, so Gary Kaufman was actually talking about, a related issue, okay, and some of the metrics that can be used. One of the things, we have a tendency to look at metrics that we can more easily find. The tongue-in-cheek comparison is someone loses their car keys at night and they look under where the street light is for their keys because that's where it's lit, not necessarily because that's where the key is going to be. So where it comes to metrics, we tend to use metrics. We can use vent days, things along those lines, but those may not be the right ones. Not that they shouldn't be looked at, but they're not the only ones that should be. Adequate staffing levels decrease the potential for error and harm. This is the AARC. We may know this intuitively, but it's an authority that's actually coming out and saying it. Furthermore, understaffing respiratory care service places patients at risk for unsafe incidents, mistreatments, delays, and the like. The math: fewer RT schools, fewer graduates, more turnover. Things are not likely to change fast. Listen, I'm not trying to sound like the prophet of doom. We have 10% fewer RT programs nationwide. We have 10% fewer graduates. These are approximate numbers. We have an aging workforce, disproportionate number of retirements. Gary Kaufman has more very specific details on this, but it's the AARC, it's really from them, is really saying we're expecting a lot of retirements coming up in the next, 5 and 10 years. High turnover. So I've just left the field. It's like, I'm gonna do something else. Bridging the gap. So that was a lot of, if you will, disconcerting news with sprinkled with some, people need to feel supported, you need to have programs, you need to, measure it and then, address it. So some of the bridging the gap, supply side, attracting and retaining, create a more nurturing environment. Millennials and Gen Zs probably demand it. Offer and promote programs targeted at preventing and treating burnout. Value-added rewards, career ladders, reward and recognition programs. At the organization I work for, they actually have a program where you got to fill certain criteria, but you can get anywhere between $2,000 and $3,000, different levels, okay, for again meeting certain criteria every year. But it's going above and beyond. It's running in services, it's doing morale builders, it's attaining additional credentials or degrees. It's doing those sorts of things. And then they have like different categories, and they have like 10, a minimum of 10 things that you actually need to do. But there's some recognition, and you get recognized, and then you also get recognized financially. It's not a ton of money, but it's $2,000, $2,500, $3,000, depending upon the level. Keep salaries and compensations competitive. Don't show discipline-specific favoritism. So recently, again, our hospital does a lot of things really well, some things not so well. Nurses got a 7% increase, respiratory got a 4% increase. So it's really, and just like, okay, so you nurses work hard, particularly in the units, we work hard, and it's just like, okay, we appreciate what you're doing, just not as much as nursing. It's like, really? Yeah. Reevaluate and revise all of the above. So you constantly, in one of my other lectures, I actually talked about, continuous quality improvement. You're always looking, you're always, making these strategic, structured improvement changes. You're seeing how they actually, do or do not work, the impact that they actually have. You're refining them further, you're measuring. So it's kind of this continuous quality improvement process that's going on. Bridging the gap, demand side, redesigning how we deliver care. Don't expect to do the same thing the same way with less. If you're consistently short-staffed, shift some of the responsibilities to nursing. Again, it may just be a temporary thing. I don't think our profession is going away, by the way. I know of a director who, when they're really short, will actually call the floor, and it's all ordained. We'll call the floor and say, listen, I had 2 sick outs tonight. I'm unable to fill those positions. Can you work with the rest? Can you have your staff to work with the respiratory therapists in order to help, to address this and get the work done? VBG, so venous blood gases. We actually do a point of care testing, but we don't draw it. So we will actually do the VBGs. We'll run the VBGs, but we don't draw them. So what has happened is we've shifted some of that back to the nurses and the techs. Managing, RT department customer expectations. If you're short-staffed, let nursing units and pulmonologists know. Hey, not that they're going to expect a lot different, but then they kind of know if there's a delay, it's not necessarily the actual therapists themselves. Expand the use of protocol-based care. So things like assess and treat protocols, where, let's face it, every patient who's prescribed bronchodilators Q4 or Q6 doesn't necessarily need them. Maybe they could be converted to a PRN. Medanebs are not for all patients in the ICU or whatever. It's not a prophylactic thing necessarily. There's no evidence to say that it could be effective as a prophylaxis against atelectasis. Reduce low dividend activities. So things like, particularly when you're shorter staff, but manual CPT versus using the bed versus using an aerobica or a vest or some other methodology may be the way to go. So some take-home points here as I come down the home stretch. Burnout is a real phenomenon, may or may not warrant medical attention. However, post-traumatic stress disorder is a diagnosis / disease. Requiring medical intervention in essentially all cases. When I say requiring it, if they don't get it, there's going to be consequences, and that is you just have somebody who may drop out of the workforce, may end up being a liability in some manner, to to the family, and affect productivity, affect quality of life, et cetera, et cetera. So really, to avert those things, it really needs medical intervention. They're both deleterious to clinicians and the organizations for whom they work, and also just society more broadly. COVID-19 made these phenomena worse. More will be published in these areas in the future, because even like some of the articles that I read, even some that I didn't include in this presentation, they talk about other studies that are underway that will be published likely in the coming months and years. Measures can be taken to mitigate their effects. Healthcare organizations should demonstrate structured actions to help mitigate burnout and a commitment to their employees. Some recommended readings here, and again, including several of the ones that that I've included in this presentation. So with that, I want to thank you all for joining us today. And I want to say thank you for selecting A&T Lectures, and hopefully you will you'll come back to us and you got something out of this. Again, thank you and have a wonderful day.